Is adding community-focused heart scans a good idea? Shortness of breath is one of the most common medical complaints, and 60% of those that present are aged 65 years and above. Heart failure is often not the most common cause of breathlessness, but it is a well-recognised symptom associated with heart failure. In the over 65s, it is estimated that 1 in 6 presenting to primary care with shortness of breath on exertion will have undiagnosed heart failure. Heart failure is the leading cause of hospitalisations, morbidity and mortality in older adults. An early diagnosis of heart failure and early initiation of the right treatments is linked to better patient outcomes. However, the current patient pathway for those with suspected heart failure lacks accuracy. In Wales, community acute clinical teams assess many elderly breathless patients in their homes. The patient assessment involves a nurse taking a clinical history and performing a physical examination. They also record the patient's heart rhythm and take bloods. However, these tests lack sufficient accuracy and can be affected by other conditions, such as lung disease, which are more common in the elderly. Therefore, a heart scan, known as an echocardiogram, is needed to confirm whether heart function is reduced. Comprehensive heart scans are routinely performed in hospitals by specialists. This means that patients need to travel to hospital, often just to rule out heart problems. This can be particularly difficult for elderly, frail patients with reduced mobility. In addition, there is currently an under-provision of heart scanning services. Many departments are overstretched and understaffed. Pre-COVID-19, people in Wales could generally wait around 2 months for a routine heart scan. Due to the limitations of the current system, Swansea University and the Neath Acute Clinical Team decided to undertake a collaborative research project to see if adding focused heart scans to the assessment process could improve the accuracy and quality of community care. Small, affordable handheld ultrasound machines, as pictured, are battery-operated and fully portable. This means that they can be used almost anywhere without having to transfer patients. Basic heart function can be assessed, which enables healthcare professionals to improve the accuracy of their clinical assessment and allows appropriate treatments to be started sooner. They can help identify patients that do or do not require a comprehensive heart scan. There is also some evidence that including focused heart scans can reduce costs because the absence of pathology can reduce the need for further testing. However, it is important to point out that these focused scans are not an alternative, equivalent, or replacement for comprehensive heart scanning by experts. Instead, they are intended as an extension of the standard physical examination. Although there is evidence showing benefit from including focused heart scans, use has not been previously tested in the community nurse care setting. Therefore, we wanted to look at whether adding a focused heart scan allowed the nurses to make better decisions about whether the patient's breathlessness was related to heart failure. Because of the lack of previous evidence in this setting, we took a cautious approach and split the study into 3 phases. Firstly, we looked at whether we could teach nurses how to do the test during a short course. Secondly, we sought to assess whether they could do it accurately on real patients in a controlled environment away from the community. Lastly, we wanted to assess whether they could do it accurately on elderly patients in the community and what impact this would have on care. 4 nurses without previous cardiac ultrasound experience enrolled. The training programme consisted of 4 components. A pre-workshop training manual was produced and emailed prior to the workshop to supplement the workshop lectures. An introductory 5-day workshop was developed to provide theoretical knowledge and hands-on practice. A subsequent practice period was provided to further develop scanning and interpretive skills. Theoretical learning was assessed via multiple choice questions, video case reviews and evaluation forms, both post-workshop and post-practice period. Practical learning was assessed via an informal practical assessment. All 4 nurses completed the workshop. For the written part of the post-workshop assessment, the average score was 86%, with a range of 82 to 93%. This demonstrates successful understanding of the theoretical content. However, for the case reviews, the average score was 45%, with a range of 40 to 60%, highlighting the need for further analysis practice. The first part of the evaluation form involved rating the course format and delivery. Results were very positive and all nurses said that they would recommend the course to colleagues. 98% of all course format and delivery criteria were graded as appropriate. The only criticism identified by one nurse was that they would have preferred longer. Nurses were asked to score their perceived knowledge level pre and post workshop for each topic, where 1 indicated no knowledge and 5 indicated fully competent. The graph shows average scores. Blue indicates pre-workshop and orange post. We can see that for each topic the scores were higher post than pre. The evaluation forms ended with a few open questions. The first pie chart relates to what was most useful, and we can see that hands-on practice, shown in blue, and case reviews in green made up the majority. The second pie chart showing how could delivery be improved shows 50% of responses stated it was sufficient, and more hands-on practice made up 33% of responses. The third pie chart shows that the main additional training requirement was more hands-on practice. If we review the 3 pie charts collectively, we can see that hands-on practice, shown in blue, makes up the majority. Unfortunately, we don't currently have results for the post-practice period assessment because training had to be put on hold due to COVID-19. Results so far show that a 5-day training workshop is sufficient for providing background theoretical information. However, it is clearly insufficient to provide the necessary practical and interpretive skills because results were much lower for the case reviews section and the evaluation forms revealed the need for more scanning and reporting practice. This is as predicted and why we designed the subsequent practice period. Analysis of the post-practice period data will provide information about whether this was sufficient for trainees to develop the necessary scanning and interpretive skills. Stage 2 of the project is a formal diagnostic accuracy study to test the nurse's accuracy at detecting reduced heart function. 100 clinically stable patients, both with and without reduced heart function, will have a focused scan performed by a nurse and by a qualified expert. The reference test will be previous comprehensive heart scan or MRI result. To ensure repeatability, 20% of patients will be invited to re-attend 1 month later and will be scanned by the same nurse and a different nurse. If results are favourable, we will progress onto the clinical stage. Stage 3 is a comparative clinical accuracy study. After the standard assessment, the nurse will document their diagnosis and management plan. Then they will perform a focused heart scan and record if or how this would hypothetically alter their initial diagnosis and management. Once blood results are back, they will again document if or how this would influence their initial diagnosis and management. Lastly, a qualified expert will remotely interpret the nurse's images. The accuracy of the pathway will be compared at the 4 time points specified. We will compare time to diagnosis, appropriate referral rates for comprehensive heart scans, and interventions started or stopped. Because scanning hasn't been previously tested in this context, nurse management will be based on the standard model of care. However, any concerns about severe pathology seen on the scan will be raised with the lead physician immediately. To summarise, nurse-led focused scanning could potentially revolutionise diagnostic community healthcare. It could improve community care and reduce the need for unnecessary referrals to more expensive levels of care, thereby offering better value, more prudent healthcare. However, there is a pressing need for a thorough evaluation of its accuracy, reliability and impact to ensure safe, effective, evidence-based healthcare, hence our research project. Should you have any questions, feedback or require additional information, please feel free to contact me on the email address provided. This is a collaborative research project between Swansea University and Swansea Bay University Health Board, and I am presenting on behalf of the research team. Thank you for your time.